Welcome to the Practice of Medicine podcast from the Southern Medical Association. Since 1906, SMA has had a singular mission to provide medical professionals with the resources they need to learn from each other and in doing so, improve the overall quality of patient care. The Practice of Medicine podcast is just one of the ways we do that, as we discuss a wide range of topics including multidisciplinary approaches to patient care and new innovations in medical technology. To learn more about SMA's many other services and educational initiatives, please visit us at sma.org.
In the conclusion of this multi-part podcast series, Dr. Benjamin Broome, a nephrologist with Nephrology Associates in Birmingham, Alabama, is joined by Drs. Elizabeth Edwards and Donald DiPette, both of whom are on faculty in the Department of Internal Medicine at the University of South Carolina in Columbia, to discuss proteinuria. Thank you for being here.
Happy to be here.
Thanks, Hugh.
It's absolutely a delight, Jennifer.
Thank you for your time. Today we are talking about proteinuria. Could you tell us what that is and how it is diagnosed?
Certainly. So proteinuria is exactly what it sounds like. It's the detection of proteins, and that's a very non-specific word in a lot of ways, but protein in the urine. Historically, on a quantifiable number, it's greater than 150 milligrams a day, but the presence of protein in the urine, for all intents and purposes, is not normal or potentially is not normal and warrants some further investigation or thought. The easiest way to pick this up, and I would say probably how this is typically, at least initially diagnosed, is with a very simple urinalysis, just a dipstick urine test that you might get on a yearly screening exam. Often OBGYNs pick this up a lot because they're always looking for protein in the urine in their pregnant patients. But it's just a dipstick that indicates that there's a presence of protein in the urine, and it starts the cascade of questioning and investigation as to why that is, and is it something we should be concerned about, something that needs to be further worked up and or treated.
I run across quite a few patients that I'm doing a urinalysis for whatever reason, and there is a little bit of protein in the urine. I recheck it and it's gone. Can you talk a little bit about what some of the benign causes of proteinuria are that I should be concerned about as a primary care physician?
Sure. So I think to get to the answer to that question, we need to be aware that when we're thinking about protein in the urine, that protein can be coming from anywhere on the urogenital tract, from as high up as the glomeruli and being spilled during the filtering process that the kidneys do, all the way down to the urethral opening. Okay, the cells that line that entire tract can potentially cause or be the explanation for protein in the urine. Okay, so as a nephrologist, obviously my biggest concern is what we classify as glomerular proteinuria, or protein that's being spilled at the level of the glomerulus. That is always where my mind's going. But there's also what we call tubular proteinuria, or proteins that come from the collecting tubules or the proximal tubules or anywhere down the tract. And then there's also, what we could classify as post-renal proteinuria. So a UTI, for example, can cause enough inflammation in the bladder and surrounding, systems or tissues rather, to where those cells can slough off. And if you just with a simple urinalysis can pick up protein in the urine. Some other benign causes, which we sometimes don't necessarily appreciate or think about all that much of the time. There's something that's called exercise-induced proteinuria. All right, so for whatever reason, and I'm not going to say that there's clear consensus of why this happens, but if you have someone who's been doing a lot of marathon training or cross training or workouts or exercise in general, that in and of itself can induce a transient proteinuria. And then another one that we often don't think about is orthostatic proteinuria. And these are cases usually in younger adults, maybe on the magnitude of 5 to 10% of the time, where when they are upright and walking around and doing their day-to-day, if you check a urinalysis during that period of time, you may detect protein. However, if they've been supine or sleeping and you check a urine first thing in the morning, that protein's not present. And those are benign causes. They don't require further workup if that's what you determine is the cause. I would say significant proteinuria, to make that diagnosis, you do need to have more than one isolated test for proteinuria. If you detect a degree of proteinuria on a random check and you bring a patient back a week or two later and you recheck it and it's completely normal, then it's usually just reassurance. You say, I don't know what's going on. It could have been some medication induced. It could have been some exercise induced. You could have had a little bit of a fever. You could have had a mild UTI going on, a lot of inflammation, other things. But the fact that it's not persistent should give you very good peace of mind that there's not something more sinister going on that requires exhaustive workup.
Ben, before we get into more specifics, I often hear the word albuminuria, microalbuminuria, proteinuria. Right. Now, I do remember from biochemistry, albumin is protein, so obviously I'm aware of that, but what's the difference when we use these three terms?
Yeah, so the main thought of using these different different languages or determinations is that albumin is thought to be spilt from the glomeruli. Okay. Now, a urinalysis picks up on albumin mostly. Okay. It can miss a lot of other unnamed proteins of differing sizes that may or may not be being spilled. The micro and the macro is really a difference in semantics and quantification. Usually less than or in and around 300 to 500 milligrams of albumin or proteinuria is considered micro. If you go over that threshold, it's considered macro. It's kind of splitting hairs as to the significance. Now, I think those terms are kind of falling a little out of favor. I think it's now minimal persistent proteinuria and moderate. I'm not exactly sure, but it's the macro micro is based on quantification and how much protein is being spilled. Some people will still order an albuminuria level instead of a proteinuria level. They both essentially lead you down the same path or tell you about the same thing. Before I forget, and we'll probably get into it a little more down the road, but like I said, the urinalysis picks up on albumin. That test strip picks up on albumin. If it is negative, that does not mean that there may not be a significant disease process going on that is causing a large degree of proteinuria. So you can't always take the urinalysis, the dipstick alone as definitive that there's not a more sinister process.
Once you establish that someone has proteinuria, does that necessarily mean automatically that that person has chronic kidney disease?
No, they're not one and the same. When we speak on chronic kidney disease, we're referring to GFR and filtering capacity of the kidney. You can have patients who have a large amount of protein in their urine and completely preserved kidney function. And you can have patients who have near zero GFR and no protein in their urine. Okay, so you can't necessarily say one and the other. So if you say that, so in the CKD classifications, CKD1 is a GFR greater than 90, which most providers will note to be a very normal number. However, if it is determined they have protein in their urine and it is determined or suspected strongly that it's from a glomerular source, that would put that patient into a CKD1 stratification, meaning that something's going on, there's some kidney disease that leads to the protein in their urine. However, at this point in time, there seems to be no evidence of permanent residual damage that has resulted in a decline in their GFR. Does that make sense?
Yeah, it does. Thanks.
Okay.
Is there an association between proteinuria and later progression of chronic kidney failure?
There is an association depending on what's causing the proteinuria. Okay, diabetes by far and away is the most common cause of proteinuria. There is absolutely a correlation between the degree of proteinuria, so how much protein is being spilled over a course of time, and that patient's chances of progression or worsening of their kidney disease and the time frame in which that may happen. Now, it's not obviously a straight line that's, one-to-one correlation, but more proteinuria, especially in a patient with diabetes and suspected or known diabetic nephropathy, you would expect a much higher chance of rapid progression than someone who has minimal proteinuria in the same diabetic nephropathy. Other diseases that can cause proteinuria that are less common, some of the glomerular diseases, things like membranous nephropathy, FSGS, minimal change disease, IgA. Yes, we track proteinuria to give us a sense of how well are we controlling or dealing with the underlying lesion. And in those cases, similarly, the less able we are to control their degree of proteinuria, the more likely that they will have significant progression in their chronic kidney disease over time.
Could you discuss some of the treatment options?
Sure. So the options really are dependent on what is causing the proteinuria. Okay. So with it being said that diabetes is the most common cause of proteinuria, especially in patients that I see. One, we want to control the diabetes as best as possible. We've talked about that in previous CKD discussions. But outside of that, we are honestly very limited in the medications at our disposal to reduce the amount of protein in the urine. Now, we know that if we can reduce the amount of protein in the urine, it's in the patient's interest in that it should hopefully slow or hinder the progression of their chronic kidney disease. Now, the class that we use, and I think most people would be familiar with, are RAS inhibitors, or renin angiotensin aldosterone system inhibitors, with ACE inhibitors and ARBs being our big guns. Okay. Every diabetic patient, unless there's a contraindication that has any degree of proteinuria, needs to be on an ACE or an ARB. Okay. Those medications should be pushed in dosage as the blood pressure allows and as any potential hyperkalemia allows, or anything else to reduce the amount of protein as much as possible. Now, other medications, other classes, again, under that RAS inhibition are things like spironolactone or aldactone. You have to be careful using dual classes because of the risk for hyperkalemia specifically. But if they can tolerate it and you don't have that issue, and you feel like you need to add a second class to try to get a little tighter control on their degree of proteinuria, it's encouraged to do so. But that's it, and it's one of the downfalls of nephrology to some degree is that we haven't had a whole lot of major breakthroughs from the pharmacological side in ways to address things like proteinuria. Now, if it's not a diabetic, if it's one of these lesser causes or less common causes rather of that's responsible for the protein being spilled in the urine, well, then you try to treat those if you can. If it's lupus, you put them on the appropriate immunosuppression medicine. If it's IgA, there's other protocols with other medicines to try to reduce the amount of proteinuria. Minimal change disease and with steroids, and membranous nephropathy with potentially things like rituximab or other immunomodulators, immunosuppression. It's identifying the cause of the proteinuria and then treating that cause and treating that disease process. And then at the same time, ACE inhibitors, ARBs are usually warranted across the board for anyone with proteinuria.
Ben, we had a specific podcast already on hypertension, but how does blood pressure or higher levels of blood pressure? I know hypertension can independently cause proteinuria, and
yes,
that's why we screen for it. But does it also exacerbate if it coexists with diabetes per se, or glomerular disease, et cetera? Is that something that we as providers should even be more diligent?
Yeah, I would say so. So the way I explain it to patients, and maybe I should have also led with this a little earlier, is that if you get down on a microscopic level of the kidney, on a glomerular level, the cells line up like a filter. Okay, blood flows on one side, toxins, waste products filter across. That's what becomes our urine and what we get rid of. Blood cells and proteins are not supposed to cross that filter. Okay, so from a nephrology point of view, if we accurately diagnose with someone with persistent proteinuria, despite the quantification, it at least raises questions in my mind. Is there damage going on to the filtering level of the kidney? Okay, now diabetes in those, specifically those foot processes of the podocytes that make up the one of the layers of the basement membrane, or the basement membrane. So diabetes commonly does that, right? It causes leakage and a leaky filter. Pathophysiologically, you see foot process effacement. The pathophysiology of hypertension and how it affects the kidney on a cellular level is not with foot process effacement. However, persistent pressure, the way I kind of explain it to patients is if you're constantly 180s, 190s, that's a pressure that can blow protein through that filter, whether the filter is intact or not. And so you may see varying degrees of proteinuria in a patient who has isolated hypertension. No diabetes, no other explanation for any degree of proteinuria, but they've been running 180s, 190s consistently. You're getting a gram and a half of proteinuria a day. You get their blood pressure under control, and you see that their proteinuria has significantly diminished or even resolved itself. So absolutely can be a different independent marker, a different point that you can follow to give indications of whether or not we're adequately controlling a person's blood pressure.
Ben, are there any clinical or physical manifestations of proteinuria that you might notice?
Certainly, and by far and away, the biggest one is swelling, okay? Edema in the feet and the ankles and the legs, sometimes periorbital edema. They'll say my eyes are all puffy, can't see. I do see that a lot. It's not an uncommon referral for me. It's usually the patient that goes in, again, for a routine checkup, or maybe this is their primary complaint in their office, and say, I've just been retaining fluid like crazy the last few weeks or last couple of months. You look at them, you squeeze their ankles and press on their legs, and you find significant pitting edema that you've never noticed before. It's never been an issue before. You have no good explanation for. That should always warrant, if nothing else, a urine dip to see if there's protein in their urine. There's other things that can cause that kind of swelling all of a sudden, but it's, the kidneys are one of the organ systems that you absolutely have to rule out. I'd say physically and clinically, the biggest indication that there may be some significant degree of proteinuria going on. Another question that I always ask my patients, or often ask my patients, is when they pass their urine, do they notice that it's really foamy or bubbly? Okay. And I say, yeah, well, sometimes there's bubbles there. And I'm like, well, no, I mean like, heavy IPA, head of a beer foamy, thick foamy, not just bubbles here and there. And some people say, well, I never look. I'm like, well, next time go look and get back to me, and then some people say, you know what, now that you mention it, yes, it's great. Like I've noticed that, and it didn't really cross my mind, but that's can often be an indication that there's a fair amount of protein being spilled in their urine as well.
But when you mentioned that person with the swelling, is that what you're referring to? Is that the nephrotic range proteinuria or nephrotic syndrome, or is those terms passé, or is it still important that I remember in medical school learning the criteria for each of these, or is it just proteinuria now is just bad and look for diagnose it and treat it?
No, good. I don't think it's passé. Again, the cutoffs are somewhat, semantic. It's nephrotic syndrome or nephrotic range proteinuria, I guess is a better terminology, is usually a patient who is found to have greater than 3, maybe 3.5 grams of protein being spilt a day, depending on the text you read. What we used to call nephritic proteinuria, or proteinuria that is present and abnormal but not quite to the range to classify as nephrotic, is usually between 300 milligrams and 3 grams. So it's not that it's unimportant for me. The quantification in that way just takes my mind to different paths as to what may be going on. Okay. Now the nephrotic syndrome and the swelling that's present, yeah, I wouldn't expect someone to come in with notable edema and swelling and those sorts of things unless they are in the nephrotic range. They're much more likely to have those symptoms if they're having nephrotic range spilling of protein in their urine. Now, most of that is due to the development of hypoalbumin anemia. Okay, right? So, we say these proteins in the urine, and we say it very nondescript because it can be very nondescript. I mean, it is albumin, but it's a lot of other things as well. And what happens is when you're spilling so much protein in the urine usually again into that nephrotic range, you overtake the liver's ability to produce albumin to make up for that. So over time, you'll develop a relatively low serum albumin level. And as we all know, a lot of the job of that albumin in our blood space is to act like a sponge. Okay, it creates an oncotic pressure to hold water in blood vessels where it belongs. If you lose that albumin and you lose that sponge factor, then the water part of our blood can leak out into interstitial tissues and third space, as we call it. And then gravity takes it down to your legs and your ankles or other places. And it takes a pretty sizable amount of protein loss to get to a point where you're having that notable clinical symptoms of, 1 or 2 plus pitting edema, if not more, anasarca, periorbital edema, those sorts of things.
Is there any cutoff of level of proteinuria after which we should refer to nephrology?
I would say no. I get consults from patients or from providers who have a known diabetic and have for a while, and they're doing their due diligence and they're checking your analysis, every several visits or once a year or whatever they may be. And they send me that patient the moment they have any degree of protein that comes up on the urinalysis or on the spot protein creatinine ratio they send, or sometimes they'll still do a 24-hour urine. The moment that it is outside of range, even the slightest bit, they will send that patient over, whether that patient has any evidence of chronic kidney disease as of yet or not. They go ahead and get them in the pipeline and just so we can also follow along. I have providers who have the same patient and have noticed some degree of proteinuria for some time, but have felt comfortable that they've got them on ACE inhibitors or ARBs and that they're watching it. And they'll wait until they see a progression or again, that it reaches a certain threshold where they'll send them over. But for the primary provider, you have to know your patient. If you've got an otherwise healthy young person without underlying medical issues and you find some degree of proteinuria and you do your due diligence and you repeat the test, a month or so later and it's still present and you don't have a good explanation at all whatsoever as to what may be causing that, that is absolutely not an inappropriate referral to make. Okay. OBGYNs, the moment they find any degree of protein in the urine, be it small or large, it's not uncommon for them to immediately send their patients on just so that we're, putting heads together and keeping a close eye on this.
This has been such an informative series. Thank you again for your time and participation.
We hope you enjoyed the practice of medicine. For more episodes in this series or SMA's The Business of Medicine podcast, go to sma.org/podcast or subscribe to us on iTunes, Google Play, Spotify, or wherever you get your podcasts. For more information about SMA's mission, please visit sma.org, and thank you for joining us today.